Julia George, and on the sofa with me this week are Roger Gough, the Conservative leader of Kent County Council, and Charlotte Cornell. Charlotte is Vice Chair of the Canterbury Constituency Labour Party. Thanks so much for joining us both this week. Let's start with the crisis in our hospitals and let's go straight to Professor Rob Galloway. Rob is a medical advisor to the NHS Support Federation campaign group, and himself he's an A&E consultant right here in the South East. Rob, I've just got in front of me now, released only on Thursday this week, new data on waiting times in A&E across Kent, Sussex and Surrey. This is for the month of December. We've got nearly 4,200 patients who waited more than 12 hours, and this is from the decision to admit. What does that mean?
So I've worked in A&E for 22 years now, and I've never seen anything like this. This isn't just a bit busy. This isn't under pressure. This is a crisis of unscheduled care. And what this means ultimately is patients who are dying because of what's happening. And the Royal College of Emergency Medicine did a paper last year in the Emergency Medicine Journal, where they looked at the data of those who waited more than 6 to 8 hours, what happened to their mortality and chance of death within 30 days. And for every 82 patients who wait more than 6 to 8 hours for a hospital bed, an extra one patient dies. And so that's how the Royal College of Emergency Medicine have extrapolated that 500 people are dying a week. And that's just not what I'm saying. That's what the scientists and the epidemiologists are saying. So this is a crisis. And if we had, for example, 2 plane loads of people crashing every single week, there'd be COBRA meetings, everyone would think it's a crisis. But because it's happening in the NHS, the most vulnerable in society, people are just saying it's a bit busy, and it's not.
There's 12 hours from DTA, from decision to admit. Does that mask even longer waits than 12 hours?
Yes. So the 12-hour decision to admit time is not 12 hours in the department, so it's an underestimation of the number of patients who've waited for 12 hours. And it would be much easier if they just released the data on those who wait more than 12 hours in the department. So 12 hours for a decision to admit can actually be variable depending on the ways the hospital measure it. It could be from the moment that an A&E doctor has referred to a specialist, so you could wait a couple of hours to see an A&E doctor and then they refer, so it could be 14 hours, or it could be from when an A&E doctor has referred to a specialist and they see a senior from the specialty team. So that could be up to 8 hours, for example. They've seen an A&E doctor, then they've seen a junior medical doctor, and then the medical registrar, for example, comes and reviews them. So a 12-hour DTA, you may have someone in the department for 10 hours and the clock hasn't even started. So you could have people in the department for, say, 20 hours and it doesn't count as a 12-hour DTA. And so the 12-hour DTA times are an underestimation of what is happening in emergency care at the moment.
I really appreciate you explaining that. Thank you. Give us a sense of what it looks like in a typical day in A&E right now.
So this isn't about my hospital. This is about hospitals up and down the country from speaking to everybody. It's really demoralising and heartbreaking for us as staff, but really more importantly for the patients, because there are often 20, 30 in a corridor, and these are patients who can wait in a corridor for up to a day. And when you're being cared for in a corridor, subtle signs of deterioration are missed, and that's why people have increased mortality. Then they may go from a corridor space into a cubicle, and they could wait for 2 to 3 days for a hospital bed from a cubicle. And this is not a way to run emergency medicine departments. It means that our emergency medicine departments are full of patients who should be on the wards. So this is in many ways not a crisis of emergency medicine. This is a crisis being played out in emergency medicine departments, and because we cannot get our patients onto the wards. And the patients on the wards cannot get out of hospital because there's so many medically fit for discharge patients, and that's because there's not the social care available, people like home care helpers, and that is the fundamental problem. This is a problem really of social care, but showing up in emergency medicine departments.
What exactly are the causes of the crisis? Is it simply down to COVID and flu?
No, this has been a ticking time bomb for the last 12 years, and it is fundamentally because the way we've been running our NHS. And COVID and flu have been the straw, but the NHS's back has been broken the last 10, 12 years, and that's because of a lack of funds and a lack of beds and a lack of staff. And if you look at our staffing numbers, they are woeful compared to Europe. If you look at our number of beds per 1,000 people, we've got half the number of beds, say, that Germany have. And so we just cannot cope with any surges. And this is what's causing the crisis, and this is why we've got such problems, and our patients are really being affected now. And so it's not just A&E times, because ambulances cannot to offload their patients because there's so many patients in A&E corridors. The waits for ambulances are getting ridiculous. It's longer than 90 minutes on average nationwide to get an ambulance for chest pain. So these are patients, for example, who may be having a heart attack, that we're not getting to them in time. This is why this is a crisis of care in unscheduled care at the moment.
How does it feel as an emergency doctor to know that there are people's lives you could have saved?
So it's hard to tell on an individual basis at all. It's all about small factors in terms of you cannot tell if someone's deteriorating as quickly, for example, so there's subtle signs you miss. I know as an emergency medicine consultant and all the colleagues I work with, the nurses, the physios, the radiographers, the pharmacists and the nurses and junior doctors, we are working and doing absolutely everything we can. Despite how difficult it is, I'm incredibly proud of what my team and what I do and what my colleagues do, because we are working incredibly well in incredibly difficult situations.
And please, I just want to say, I don't want to say, Rob, that there was no implicit criticism of you. What I really meant there was, how does it feel to know somebody died at home before they even got to you?
It's, you know, it's awful, but we're doing what we can in a really difficult situation, and the question really shouldn't be put to NHS workers. It should be given to the people who are managing the NHS, which is our politicians. You know, the principles of the NHS are really good. The principles of providing care, not based on profit, but based on what's right for patients, is the right thing. And if you had a really good car but was being driven by a reckless driver, you would criticise the driver and not the car. And that's where the focus has to go to our politicians, because this isn't about individual hospitals or NHS managers or anything like that. This is a political issue which must be tackled at a national level now.
I feel strongly that you're nudging me to bring the politicians in, so let's do that. But stay there with us, Rob, if you would. Rob said this is actually a crisis of social care, didn't he? Roger, let's talk about this £200 million that Rishi Sunak says is going to be spent on care home beds to help move people out of hospitals who don't need an acute bed any longer. How does that work, and is it the solution?
Well, anything that brings extra resource in and helps get people out of the sort of situations which Rob's been describing is clearly welcome. Now, I think what we are seeking to do is that much of our focus is on actually where you can get people out of hospital, or indeed, ideally, if you do the work properly, prevent them getting there, through care and support in their homes. Obviously, it depends on their conditions, but care and support in their homes. So I think there are two potential concerns about what may come out of this, though, as I say, it is in itself welcome. One is that you can have a situation where people stay in those homes for longer, and they become more dependent, and that's actually bad in terms of the outcomes for them. There is also a question mark as to what that means from the point of view of local authority social care, because at some point the cost of that could end up with the local authority, and we know what the pressures within social care are. So what was positive was that also in the autumn statement there was a relatively large amount of money that went towards social care. Clearly, you know, in the context...
But some of it hasn't arrived yet, has it?
For us, I mean, we are seeing it arriving, and we are, in fact, that's underlying a lot of the work we're doing with our colleagues in the NHS here in Kent. And I think one of the more positive features was that the relative importance given to social care was much higher than it's been in previous years. But the undoubted pressures are very, very significant.
But nationally, Roger, this funding was originally announced in September. The first tranche is just reaching local authorities now to buy those care beds. And of course, you can't, if you release the funding at the peak of the crisis, you can't prepare for the crisis. So again, this is mismanagement at a national level.
Yes, but I mean, actually, the bulk of the funding I'm talking about was actually announced in October. Was it October, November? The autumn statements. That was the funding that I'm speaking about, and clearly we now see also this additional announcement in relation to care homes.
Let me get back to Rob for a second. Is this money to help people move out of acute beds in hospitals and into any spare capacity in our care homes in Kent, Sussex and Surrey? Is this going to start making a difference quickly enough for you and your teams in A&E departments?
So any additional support to either help discharge medically fit for discharged patients or to prevent patients coming to hospital has got to be welcome. The key investment really needs to be in the community. I know I'm an emergency medicine consultant, but actually what we need to do is invest in things like district nursing, social care, community palliative care and that type of thing to really stop patients coming in who don't need to be coming in and give alternative ways of supporting them and also allow that discharge once they're medically fit for discharge. Because although, you know, hospitals are great if you need them, if you do not need to be in hospital, coming to hospital is not the right place for you because of the risks of infection. And so, yes, any investment is welcome, but the question is, this was totally predictable. The investment has been needed to be as early in this to try and help these problems.
I rather suspect, Roger, that you feel the same way as the leader of a top-tier authority who's got to deliver social care.
Well, clearly, we wish to see resource coming into social care because it's not the only element of this. There is a big element of NHS community medicine as well. But social care is an important dimension to this, and that is everything from preventing people coming into hospital through to ensuring that there is effective discharge and those services which enable reablement and recovery.
Yeah, OK. Quick thought about whether there is enough. I mean, if we want people to go home, and Rob alluded to that as well as care homes, looking after people in their own homes, are there even enough carers? Are we paying them enough? Is it professionalised workforce enough to actually be the point of solving these problems?
There are undoubtedly huge pressures within the social care workforce, and that has been, again, the case for some time. What we are seeing is, and in fact, one of the things that we're using, the funding that came through from the autumn statement for, is actually workforce development, because that, again, is a vital element of this.
Charlotte, let's talk about spending, because when Labour talks about solutions, there's always a cost attached to it. Health spending has risen in real terms in all but 1 year since the Conservatives got into government, these years that Rob was alluding to. It's not enough, perhaps, to meet the demands of our ageing population. Labour wants to invest even more. Where does the money come from?
I'm sure we have an ageing population, a vastly changing demographic, especially down here in this region. I mean, the money comes from restructure and skills and retraining in new buildings and investment in staff. And we've had 13 years of chronic mismanagement, not just of critical care, but it's of social care, it's of the buildings. We were promised hospitals,
but that's
not new
more
hospitals.
Money, isn't it? If you want to have new buildings, that's throwing more. That's not going to...
You can't make things more efficient when you have a creaking service that's falling down both literally and figuratively. So you do have to invest to save in the long run, both in people and in buildings and in structures. There has to be investment to save.
I don't feel that answers where the money comes from in the first place, though, to solve the problems we're talking about today.
Yeah, I mean, absolutely. The governments have struggled with this for years. We've had promises of reform from both of social care from both Labour and Conservative governments that haven't delivered for 20, 30 years. It is absolutely chronic.
Do we need to pay more tax for the NHS?
Yes.
Do we need to pay more tax for the NHS, Roger?
No, and I think we need to ensure that there's adequate funding. I'm not sure that we... and it's interesting to note, actually, that whatever Charlotte's answer, the Shadow Chancellor has been saying very much the spending chequebook is not open.
OK, Rob, same question to you. Would all of us who do pay taxes, would more taxes be the answer? Does that solve the problems that you're seeing and your teams are seeing across the South East?
I think when you talk about tax, we've got to talk about fair taxation and taxation of the right people, because people like nurses, teachers, that type of wage really can't afford more taxation. But there are the higher rate people or the people with a lot of wealth. So you could look at a wealth tax rather than an income tax increase, because the NHS does need investment. We've got to be honest. The average investment under the Labour years was a 6% increase in real terms. The last 12 years, it's only been 2%, and that hasn't kept up to the increase in ageing and numbers of patients we are looking after. And so that's why we're seeing the problems. But the other thing we've got to look at is also, I know we've said for some time we've struggled to recruit carers. Let's be honest, since Brexit we've struggled to recruit carers because we've lost so many Spanish and Portuguese and Italian nurses and healthcare associates and that type of thing that we need to look at our immigration policies. But there's just one thing I just want to say before I finish is I know we're talking about the problems in emergency medicine, but I just want to reassure people that if you are acutely unwell with an injury or an illness, A&E is the safest place. Most A&Es are still seeing patients quite quickly. It's just the problems about moving on to a ward. So you're getting the treatment. So please don't, if you're unwell or an acute injury, please do not come to A&E, because we are there for people who need it.
Rob,
and that's really important to emphasise at the moment.
Thank you for that message, and thank you for everything you and your teams in our A&E departments are doing across the South East right now and every day. Great to talk to you.
Thank you.
Now.